Welcome to ICU Fellowship Prepcast.
Hi, I'm Maddie.
I am Swapnil. So obviously we're joining after a bit of long break. Obviously the life has been busy for both of us. So welcome, Maddie. How's things?
Yeah, things are good, but it's been busy, like you said. So, yeah, apologies for the delay, but we're back.
And also August, September is a recruitment month. So obviously everybody's busy with recruitment and
Yeah.
looking forward to getting some new recruits for the next year. So also the fellowship exam written has been just finished. So just in the process of marking some papers. So it's really interesting to see how the questions are changing, and obviously they're trying to be a bit more relevant to clinical practice now. So there's not anymore a lot of just vague questions. Examiners are trying to ask very specific questions.
And I think that, like, it seems to be, anyway, from looking through some of the papers, that it's more structured or like more multi-part kind of questions now.
That's right. And the rubrics have been very well developed now. And also, the examiners are trying to tell you which sub questions are carrying how much marks so that you can focus and answer those specific parts of the questions in that order. So let's dive into today's snippet. A 50-year-old male returns intubated to ICU following a laparotomy, splenectomy, and a partial hepatectomy for intra-abdominal bleeding following a high-speed motor vehicle accident with an isolated abdominal trauma. He has had a massive transfusion in operating theater. Can you please outline your initial assessment upon his arrival in ICU from the operating room?
So my assessment would involve initial stabilisation and handover from the theatre staff, a targeted history of his background, details surrounding the accident and treatment to this point, a thorough examination and specific investigations depending on the findings of above. So in terms of the initial stabilisation and handover, I think a lot of us do this routinely when people come back from theatre. So it's connecting patient to our ventilator, likely on a mandatory mode, as usually they are paralysed before transfer, connecting to our monitoring and assessing a brief assessment of the vital signs, including ensuring that there's good end-tidal CO2 trace and hemodynamic stability, reviewing the current sedation, analgesia and vasopressors or other blood products that are currently running from theatre and transferring to our infusions. And getting a handover from the anaesthetic and operative staff, including things like the grade of intubation, the blood products used. We know he's had a massive transfusion, but was that balanced or was that rotor guided? Any drugs, including antibiotics or ADT, given it was a trauma? What access he has in the surgical details, if there's any plan for further surgical intervention, the drains in situ, and whether there's any C-spine precautions. It says an isolated abdominal trauma, but whether this was cleared pre-operatively. And from a history perspective, this would be about the patient, the details of the accident and his trajectory, or likely a brief trajectory, but his trajectory in hospital so far. So from a patient perspective, we know if there's any background history, regular medications, especially if there's any anticoagulant or antiplatelet agents that have been used, any allergies, and if his next of kin are aware and have been updated. Then in terms of the accident, the details of the accident, whether it was high speed or a significant mechanism, the vitals, GCS and treatment provided on the scene, and the trajectory since retrieval from the scene in hospital. And then his trajectory in hospital with any investigations and management done till now. So his last blood test, whether there was a rotor done, any results of trauma scan or imaging, medications given to this point, and then the operative details. And then we'd move on. This would be like a simultaneous assessment and management. So we'd look at the examination with doing a brief repeat of the primary survey. So looking at the ETT size and position, end-tidal CO2, and as I mentioned, the C-spine clearance, the adequacy of his oxygenation and ventilation, especially in context of MTP, where they're more likely to have things like an acute lung injury. Looking at the circulation, his hemodynamics, and any support required. The current GCS, I would assume, would be 3 at this point, is usually they're sedated and paralysed for transfer, but it's pupils and what sedation and analgesia is running. And then his temperatures, he'd be at a high risk of hypothermia due to the MTP and the OT time. Looking at obvious bleeding or deformities and looking at the surgical site, drains, and the lines in situ. And then depending on the stability and findings of that, doing a secondary survey, so looking at starting from top to toe, I'm looking for any significant injuries, and when he's rolled, assessing the back and perineum for any signs of injury. Then from an investigation point of view, we can class that into bedside bloods and imaging. From a bedside perspective, like an admission ECG and an ABG, and this will be looking at gas exchange, hemoglobin, and ionized calcium, blood, rotum if significant bleeding, full blood count, coags, and organ function, and imaging a chest X-ray for line and tube position, and would consider further imaging depending on the results of the assessment.
Thanks, Maddie. So I guess one of the way to look at it is almost like a Formula One analogy for this is when the car comes into the pit where all people are standing and then waiting for a car to come in the pit, and then you're ready to take a handover. The two components of this handover, one is obviously the anesthetic handover goes into more of a physiological component of the patient's state and what interventions happen intraoperatively. And the second component is obviously the surgical part of the handover, which basically what things surgically have been done and what are there any kind of intraoperative complications that you need to be aware of. So I guess during the handover, it's almost like a team approach, making sure that there's a clear one person is speaking and everybody is listening, and that's clearly important, because if the handover is really chaotic, then it becomes really, you can miss out on very key important details. Also making sure that the surgeons and surgical assistants or the nursing staff do hand over about the drains and what the expectations are and what target parameters do they really want to aim for these patients with regards to their hemodynamics, their vasopressor requirements and all those things, and what are the kind of thresholds where they want to be called to reassess the patients. So can you please outline now your management for this patient for next 24 hours?
So broadly, I think this is involved ensuring hemostasis and preventing further bleeding, respiratory support, identifying complications from the trauma and interventions, and identifying and treating any management plan for any other injuries, pain management, and then supportive care and a tertiary survey later down the track, depending on if he's extubated and accessible. So going into a bit more detail from ensuring hemostasis and preventing further bleeding. We know that this gentleman's had a significant trauma, has had an MTP already, so I'm wanting to optimize the coagulation status, aiming normothermia with a temperature of 36 degrees or more, an ionized calcium greater than 1.1, and I'd be doing rotor-guided product replacement and having close monitoring of his hemodynamics, drain output, hemoglobin and coagulation parameters. If there's worsening hypotension or high bloody drain outputs, then escalating rapidly to the surgical team regarding need to return to OT or for a rescan. From a respiratory support, we know that he's still intubated and ventilated, so the aim would be to try and progress towards extubation depending on his stability and requirement for further surgeries and respiratory status. So initially aiming to change him to a spontaneous mode of ventilation and weaning his parameters till extubatable. From a trauma perspective, I identified complications from the abdominal trauma specifically or the intervention, including things like abdominal compartment syndrome. So is there a need for further imaging and then monitoring end organ function with things like liver function tests and looking at his renal function? And then aiming to identify, treat, and make a management plan for any other injuries. So it says it's isolated abdominal trauma, but ensuring that there's the C-spine has either been cleared or having a plan in place to clear the C-spine if that's not already done. So reviewing his imaging, previous GCS and limb movement. And then from a pain management perspective, he's had significant trauma and an operation. So regular paracetamol if the remaining hepatic function allows, an opioid infusion initially and transitioning to enteral opioids if it's absorbing feeds and getting ready for extubation. And then thinking about things like low-dose ketamine or adjuncts if issues with pain control. And then from a supportive care perspective, so things we think about, like including things like the fast hug, so mechanical DVT prophylaxis initially, and then depending on his stability from hemostasis perspective, reviewing about starting chemical prophylaxis, and that will often be within the first 24 hours if there's no signs of ongoing bleeding. A PPI is intubated, and nutrition. So I'd be starting NG feeds if he's not hemodynamically unstable and his aspirates are guidelines are less than 500 mils in 6 hours and periods. And then something to always think about is the tertiary survey, but this would be once he's extubated and accessible, which may or may not be in the next 24 hours, depending on his progress.
Yeah, that's right. So almost like a fast, I guess, approach will be quite useful to structure or answer for this type of questions. Yeah, and I think important thing will be the communication with the family and updating them about the status in ICU, and obviously what's the plan of communication in terms of if things change overnight or in next 24 hours, how they like what are the kind of plans around those things. So or what the family should anticipate over next 24 hours. Yeah, it's also a part of 24-hour management plan. Now, let's say potentially this patient had a splenic laceration intraoperatively. How are normally splenic injuries are graded?
Yeah, so we know he's had a splenectomy from this, for the stem. So in terms of how a splenic injury is graded, so the most commonly used grading system is the American Association for the Surgery of Trauma, or the AAST splenic injuries scale, and that's where they're graded into 5 categories. So grade 1 is, and the categories basically subdivide the injuries depending on the amount of subcapsular hematoma there are, the size of a parenchymal laceration, and whether there's a capsular tear and the extent of that. So it goes from grade 1, where there's a subcapsular hematoma less than 10% of surface area, parenchymal laceration less than 1 centimetre in depth, and a capsular tear, all the way up to a grade 5, which is the worst, which is a shattered spleen, or any injury in the presence of a splenic vascular injury or active bleeding extending beyond the spleen into the peritoneum. And you can have a look at the show notes to see more details. But generally, grades 1 to 3 are managed conservatively if the patient is hemodynamically stable, whilst grade 5 often, but not always, requires intervention via angiography and embolization or surgery. But this is with the caveat that any grade of injury, if they're hemodynamically unstable, would generally progress through at least looking via angiography, whether there needs to be embolization or further intervention.
Yeah, that's right. And sometimes even the grade might be minor, like 1 to 3. But if there is a pseudoaneurysm of the artery because of the injury, they will tend to go for embolization in that case, anyways. Now, as you mentioned, this patient had a splenectomy. What are the kind of signs of asplenism or hyposplenism on the blood test?
Yeah. So this is like been actually in previous exams as well, like trying to identify signs of asplenism. So the main things are on blood film. So how jolly bodies, which are basophilic inclusions within red blood cells, and they represent the remnants of nuclear DNA. Acanthocytes, so these are uneven spiky projections on the red cell membranes, target cells, spherocytes, or Pappenheimer bodies. Other signs that someone might have asplenism or hyposplenism is a thrombocytosis, a monocytosis, or a lymphocytosis. But the most characteristic thing is how jolly bodies.
Yeah, and often this the thrombocytosis or macrocytosis, it takes some time to develop, especially after the splenectomy. So it won't be the immediate change post-operatively. Now, obviously, this question comes often in the ward rounds, especially when you see the patients with splenectomy. What are the kind of guidelines around post-splenectomy vaccination, and what are the kind of vaccinations are essential for these patients who don't have spleen?
Yeah, so we do get this very commonly, like you said, asked about vaccinations within the ICU. So the current guidelines say that the patient should be vaccinated, but it should be at least 7 days after an emergent splenectomy. The guidelines are a little bit different for elective sort of splenectomies. Even though it says 7 days after emergent splenectomy, it's recommended when patients are very stable. So it's often given on discharge from hospital. So it's often not a problem that we sort of have to face within the ICU. The vaccinations, the most important things are to protect against encapsulated organisms. So the vaccinations that are recommended, the pneumococcal vaccine, and there's different types of vaccine. So there's the conjugate vaccine, which is first recommended, and then there's another kind of vaccine, the 23B PPV vaccine, which is recommended 2 to 12 months later, and then again 5 years after that, if they haven't received 2 doses previously. Then the other important one is the meningococcal vaccine. So there's Men-B, which the recommendation is 2 doses 8 weeks apart, and then the Men-ACQY, which again is 2 doses 8 weeks apart, but also recommends a booster every 5 years. Other vaccines that are recommended are the Haemophilus influenza type B, but only if they haven't had the vaccine previously. The RSV vaccine, if they're aged 60 or older. And then the annual influenza vaccine is also recommended.
As you rightly said, 99% of the time we don't give these vaccines in ICU. We usually just wait for them to get discharged from hospital. At that time, that they get all these vaccines. However, we do cover them with appropriate antibiotics. So what are the current prophylactic, like antibiotic recommendations for these patients?
So the current recommendation is amoxicillin, 250 milligrams orally daily, or phenoxy methylpenicillin, 250 milligrams BD orally. Then if people have allergies to penicillin, if it's non-severe, the recommendation is for cefuroxime. But if it's severe, the recommendation is, because penicillins are actually superior in this case. So there's a strong recommendation to consider performing desensitization. But if that's not possible, then the recommendation is for azithromycin. The duration is for at least 3 years post-splenectomy, but consider it for life, consider giving it lifelong if patient has survived overwhelming post-splenectomy infection, especially if it's pneumococcal or if they're significantly immunocompromised. And it's really important that these patients have an education and emergency plan. So if they develop a fever, they should seek rapid medical review. And it's usually encouraged that they have an emergency supply of antibiotics, which is usually a bigger dose of amoxicillin, so 2 grams initially while they're waiting to see a doctor.
Yeah, thanks, Mani. That's a very comprehensive coverage of all the antibiotics and vaccine guidelines. So that's the end of our today's snippet. We'll be back with another snippet shortly. Till then, goodbye and have a nice time.
Thanks for listening. See you next time.